So today we'll be discussing about Mycobacteria and as well as systemic mycosis. So among Mycobacteria, I'll be discussing mainly on Mycobacterium tuberculosis. So as you know, as a whole, the genus Mycobacteria, it has certain characteristics. So first of all, they are acid fast. So acid fast, for to see acid usually do Jaden stain. So we can see whether the organism is acid fast or not. So this Mycobacterium belongs to acid fast, and this acid fastness is due to the certain components, that is mycolic acid, which is present in its cell wall, and because of this component, it has its acid fastness property. Then they are obligate aerobes. Obligate aerobes means they cannot grow in absence of oxygen. Other characteristics are they are non-motile, non-sporing, non-capsulated, and straight or slightly curved rod-shaped organisms, sometimes showing filamentous forms. Usually we don't do gram stain for them, but if you refer to gram stain, then they are weakly gram positive. Then the classification of Mycobacteria will be Mycobacterium tuberculosis complex, then uh, Microbacterium leprae, and non-tubercular Mycobacteria. So today I will restrict my discussion to Mycobacterium tuberculosis. So the different Mycobacterium tuberculosis complex, which are the organisms which come under Mycobacterium tuberculosis complex, they are basically tuberculosis, M. tuberculosis, Mycobacterium bovis, capri, africanum, and you can see the entire list which goes on. Among which tuberculosis is the one, M. tuberculosis is the one which is the human tubercle bacillus and is responsible for tuberculosis in human beings. So, what are the antigenic structures of a Mycobacterium tuberculosis? So it has both cell wall antigens as well as cytoplasmic antigens. So cell wall antigens are insoluble antigens, whereas cytoplasmic antigens are soluble. So what are the cell wall antigens? So like any other bacilli, any other bacteria, it also has a peptidoglycan layer. So as you have already discussed, the importance of peptidoglycan layer in terms of gram positive and gram negative organism, that basically it gives responsible for the shape and the rigidity of the organism. So similarly here also it maintains shape and rigidity of the bacilli. Then additionally it has arabinogalactin layer. This arabinogalactin layer, it is protective for the bacilli because of this layer they can survive within the macrophages. The macrophages are defensive cells of the body and they can survive within the macrophages because of this layer. Then they also have additionally a mycolic acid layer. So mycolic acid layer is the principal constituent which confers very low permeability, acid fastness, and reduces the entry of most antibiotics. So the acid fastness that we see in Jaden stain or Jean-Nielsen stain is mainly due to the mycolic acid layer, and also it reduces the entry of antibiotics, means it reduces the permeability of antibiotics into the cell. Then other outermost layers we have lipids, glycolipids, and mycosites. So besides them we have proteins like porins and transport proteins, which is found throughout the various layers. Then plasma membrane. So plasma membrane role is it helps in attachment to host cell and is also target antigen used for diagnosis. Then we come to the soluble antigens, which are different names like antigen 5, antigen 6, antigens. And basically they are used in serodiagnosis of tuberculosis. So we come to pathogenesis. What are the source of infection? So the source of infection is human case of a pulmonary TB, or a bovine source can be an unpasteurized infected milk. So how it is transmitted? It has a inhalational mode. It is transmitted via the droplet nuclei. So these droplet nuclei are very tiny droplets, less than 5 to 10 micrometer in size, and they can remain suspended in air throughout there for several hours, and so they are easily inhaled. So when it is generated, when these droplet nuclei are inhaled, usually when a patient having the infection is coughing, sneezing, or speaking, then these nuclei are transmitted by the inhalational mode. Besides inhalational mode, we have other modes of transmission like inoculation and ingestion. Any doubt so far?
Ma'am.
Okay, shall I move on?
Yes, ma'am.
Okay. So if you
Yes,
get
ma'am.
any confusion, any doubt, please ask questions in between if you get any confusion. Okay. Okay, we'll just move to the next slide. So what are the risk factors which is favoring transmission? So sputum positive patients with bacilli load of at least 10,000 bacilli per ml. That means whenever we look for a sputum smear in sputum smear microscopy after Jaden stain is done and we found a positive smear, that means we detect as it was bacilli in the stain, and this is possible only when the load of bacilli is quite high. The load of bacilli should be more than 10,000 bacilli per milliliter of the sputum sample. Then only it is detectable by sputum microscopy. So such patients, those patients which are having sputum positive smears, they have a higher chances of transmission of the organism compared to sputum negative patients. Then those patients which are having cavitary lesions in lung, so they are having, obviously because of the cavitary lesions, they are having a higher bacillary load. So higher bacillary load means they are more infectious compared to other patients. Then in the certain conditions, like how the patient is inhibiting, or how he is staying. So if the patient is staying in a poorly ventilated house, poorly ventilated room, where lots of people are there, when there is overcrowding, then usually the transmission is high. Then, if the patient is having another disease, another infection, like a co-infection of HIV, then the chances of transmission is high. Besides this, there are certain comorbid conditions like post-silicosis, post-transplantation hemodialysis, diabetes, IV drug abuse, smoking. So these are the other conditions which also increases the chance of transmission. And there is also age and gender factor. So next is your sequence of pathogenic events, means how the pathogenesis occurs inside the human body. So first is, as you all know now, it's the inhalation mode. Okay, from the inhalation mode, there will be droplet nuclei. So droplet nuclei are inhaled, and after inhale, they are trapped in the upper airways. Okay, so majority are trapped in upper airways and expelled out. Means if the defense mechanism is good, patient is having a good defense mechanism, then most of the bacilli are expelled out of the system, and usually less than 10% reach the alveoli. Okay, so once it reaches the alveoli, it adheres to the macrophages. It has those antigen like lipoalbumin. So lipoalbumin, it helps in the internalization. Internalization means the access of the bacilli inside the macrophages. Because of this antigen, if it binds to the complement receptors and the mannose receptors, so there is this internalization, or the bacilli, it can get an access into the macrophages. So into the macrophages, sometimes the phagocytosis by macrophages or by enhanced beta complement system mediated oxygenation of bacilli may take place, but the survival inside the macrophages is also possible for tubercle bacilli, because the cell wall LAM or lipoarabinomannan, it impairs the phagosome lysosome fusion. In order to be phagocytosed inside the macrophages, there should be phagosome lysosome fusion. Then only these enzymes will act on the bacilli and disintegrate or cause lysis of the bacilli. But since this, because of this antigenic component, they can evade this system. They can survive inside the macrophages and they can replicate inside the macrophages. Not only they can survive, but also they can multiply or replicate inside the macrophages. Eventually, the macrophage will be ruptured and there will be the dissemination of the bacilli. That means the bacilli will be released into the system after the macrophage is ruptured. Are you clear with the pathogenesis?
Yes, ma'am.
Okay. So different kinds of responses occurs. Like one is a macrophage activating response, then tissue damaging response, and humoral immune response. So I'm not going to details, but just what is a macrophage activating response? They are basically they have the patient have the tubercle formation. That will be hard tubercles and soft tubercle. So usually it's a defense mechanism, because this is one way of responding to the bacilli, to the foreign antigen. So that is one macrophage activating response. Then we have the another responses, then the tissue damaging response. So uh, So minority of cases, which is associated risk factors, so macrophage activating response is weak and bacilli more virulent. That means, in case of when there is the infection by a more virulent strain of bacilli, then instead of a macrophage activating response, the patient may show tissue damaging response. And there is a humoral immune response. Humoral immune response is due to the activation of B cells. So immunology classes we have already taken, and at this time you know what is a T cell and a B cell. So the B cells, when they are activated, they leads to antibody production. Okay. So tuberculosis is an obligate intercellular organism. So humoral immunity usually has a minor role. What are other antibodies which are come into place? Anti-LM antibodies. So it plays a role in preventing dissemination of tuberculosis in children. So there are three kinds of responses which we can see in the pathogenesis. One is the macrophage activating response characterized by tubercle formation. Then there is a tissue damaging response, which is a more virulent reaction by the virulent strains. Then there is the humoral immune response, that is antibody production. Now, TB in clinical manifestations, it can be broadly classified as pulmonary and extrapulmonary. So, more common is pulmonary tuberculosis, and we also have extrapulmonary tuberculosis, means other than lungs and its associated structures. So, it's not found. So, extrapulmonary tuberculosis is less common. So, around 15 to 20% of case, that is the number which they are given. So 80% in case of pulmonary tuberculosis and 15 to 20% usually in case of extrapulmonary TB. So the difference, you should know the difference between a primary and secondary pulmonary TB. So what is the pulmonary? We have already divided the clinic according to clinical manifestations. We have pulmonary and extrapulmonary. But again, in pulmonary TB, there is primary and secondary pulmonary TB. So secondary pulmonary TB is also known as post-primary pulmonary TB. So what is a primary pulmonary TB? When the patient is having an infection for the first time, means an exogenous infection. Exogenous means an infection from outside of the host, body. So it's the first time the patient is having an infection from an exogenous source with tubercle bacilli. And post-primary means it can be a reinfection, means patient is having an patient already had an infection, again secondarily again having a reinfection, or maybe the bacilli was there in a latent form which got reactivated. So that is the endogenous method, that is the reactivation of latent primary lesion. So the classification also has the primary affected age group is commonly is children, in post-primary is adults. What are the lungs, parts of lungs affecting? Here in case of primary PTB, pulmonary TB, it's subpleural lesion. Post-primary is apical and posterior. Then in subpleural lesion, in primary pulmonary TB, it's the upper part of lower lobe and lower part of upper lobe. It's the most common site, that is the upper part of lower lobe and the lower part of upper lobe. And post-primary, usually it's the segments of upper lobes. Okay, so in primary pulmonary TB, we can see the involvement of the lower lobe also of the lungs. But in case of post-primary, it is the some segments of the upper lobes only. These are the commonly affected sites. Then what kind of lesions are formed at the initial sites? So, you know, in primary pulmonary TB is bone focus. You should know what's a bone focus. It's nothing but a fibrotic nodular lesion at the initial site. Okay, so its location is similar, that is upper part of lower lobe and lower part of upper lobe. So that is a nodular lesion known as the cone focus. And in post-primary, we can see some calcified nodules and hardly hematogenic seedling in the apex of lung, Simon's focus. So this Asman focus and Simon's focus, these are seen in secondary TB. Then in cone focus is associated with hilar limb adenopathy and known as the primary complex. And lymph node involvement is rare in case of post-primary TB. So you should know what is a cone focus and what is a primary complex. So primary complex is nothing but cone focus along with the lymph adenopathy. Are you clear? Any doubt?
No, ma'am.
Okay. So you have studied cone focus and primary complex. Okay, these are important for you. Now, regarding the clinical feature, what is the difference between primary and post-primary pulmonary TB? So, primary TB may be asymptomatic or may present with fever, productive cough. I think by the you know the symptoms of tuberculosis. So what are the usual symptoms of tuberculosis? Anyone? What are the presentation of tuberculosis? How do the patient present? So they have fever, productive cough, sometimes hemoptysis also, then characterized by weight loss. Then there is night sweating. So these are the common symptoms which are found in a TB patient. Then in a secondary pulmonary TB, the lesions undergoes necrosis and tissue destruction, okay, leading to cavity formation. So symptoms are similar but more pronounced. So it's more severe compared to primary pulmonary TB. So in case of primary pulmonary TB, the lesion spontaneously heals, and sometimes the primary complex may become calcified, so known as the Ranke complex. But the post-primary, the bronchogenic spread to the same or opposite lung forms satellite lesions or caging pneumonia. So it's a more widespread or disseminated type of lesion that you can see in post-primary. So hematoma spread to various parts of the body and granuloma formation, and rarely heals spontaneously. So this is all about pulmonary tuberculosis, but now next we move to extrapulmonary tuberculosis. Means what are the other sites which are involved? So we have tubercular pneumodinitis, pleural tuberculosis, tuberculosis of upper airways, means other than the lungs. We have lung sums in the lower airway. So in the upper airway, larynx, pharynx, and epiglottis. These are the extrapulmonary site. Then there is genitourinary tuberculosis. Then skeletal tuberculosis. Then involves the CNS, pericarditis. Okay, so these are the various sites where you can have extrapulmonary TB. The gastrointestinal tuberculosis also, skin lesions are also fine. You can see skin lesions also. Now we come to the laboratory diagnosis. Are you clear with pulmonary and extrapulmonary?
Yes, ma'am.
Okay, so you are now, there should not be any confusion regarding the site of pulmonary TB and extrapulmonary, and you should know the difference between primary pulmonary TB and secondary pulmonary TB. Okay, so which one among primary and secondary, which one is having more hematogenous spread? Which one is having more hematogenous spread among primary and secondary? If you have understood, you can answer this question. Anyone? So it is the secondary one, okay, where you'll get, because it's more severe, you can see the gazetting necrosis, and there is more hematogenous spread in this type. Okay, so laboratory diagnosis. So what will be the sample? Can you have any idea what will be the sample? What will be the sample for laboratory diagnosis if you are suspecting pulmonary tuberculosis? What will be the ideal sample? Anyone? No? So it will be sputum. So sputum, we usually ask for 3 early morning sputum samples. Okay. So spot sample and early morning sample. So usually it is three samples. And how much you have to collect? We take around 2 to 5 ml, and preferably if there is a mucopurulent part, we will consider that part, because there is the chances of yield of the bacilli is more in that portion. Okay. So what are the other specimens according to the extrapulmonary specimens? What are the optimum specimens? So sterile cell specimens collected aseptically. For optimum specimens, CSF, spinal, pericardial, synovial, ascitic blood. Means depending on the site, the specimen will change. Then suboptimal specimens where the organism load is less. So optimum specimen and suboptimal means, in suboptimal we expect the load of the organism will be less. So we need to collect more amount of the sample in order for the better results. So like for example pleural fluid. So if we are collecting pleural fluid, we should try to collect around 20 to 50 ml. Then blood is only indicated only when there is a disseminated TB or there is HIV TB co-infection. So other than this, we can collect swabs like laryngeal swabs or from the discharging sinus. Urine sample also you have to collect, and you have to take 3 early morning urine samples. And stool also for disseminated TB in HIV infected patients and infants. So besides this, other respiratory specimens which we can collect: bronchial secretions, bronchoalveolar lavage, transbronchial and other biopsies. Then gastric lavage. So gastric lavage has an importance in pediatric group because it is recommended for children, because children usually has a tendency to swallow sputum. So for them, gastric lavage is a preferred sample. Or also the patients which are in ICU or which are then for them also this early morning lavage will be collected and processed. Means they cannot produce their own sputum. That's why from those patients we can collect your lavage sample and process early. Means once it is collected, we should be ideally processed in less than 4 hours. Next, once the sample is collected, so for different samples, the different amount of, means for different specimens, we have to collect different amount. Say from this, like from a sputum sample, we need around 2 to 5 ml. Okay, but since in a pleural fluid, the yield of bacilli is less, so we need more amount of sample, like 20 to 50. That means depending on the sample also, the amount of sample may vary. And in case of a pediatric age group, the gastric lavage is a better sample because the children usually they have a tendency to swallow sputum, and also in ICU patients. Now once the sample is collected, next we have to process the sample, but before we process the sample we do certain steps, means preparation of the sample. So it involves digestion, decontamination and concentration. So why digestion? Because if there is a thick purulent pus or thick pus, we want disintegration of the puses and homogenization of the sample. Then why we need decontamination? Because sputum may have certain normal flora. So we don't want the normal flora, so we want to remove them. So that we need decontamination. And concentration is done so that the yield or the bacillary yield can be increased. So two methods are employed for concentration methods of sputum, that is a Petrov's method and NaLC or sodium hydroxide method. So this NaLC sodium hydroxide method is a preferred method over Petrov's method. So here this N-acetyl L-cysteine, it actually liquefies the sputum, and sodium hydroxide, it helps in killing the, means removing the normal flora. So it's a more compatible and a superior form of concentration method compared to Petrov's method. Are we clear? Any doubt?
No, ma'am.
Okay, so I'll move to the next slide. So this is a picture. Can you see?
Yes, ma'am.
You can see, everyone can see the image?
Yes, ma'am.
Okay, so this is a Jadenstein. Okay, this is how a Jadenstein smear microscopy looks like if you see under microscope. So basically here you can see the pastors and the bacilli. So these bacilli, they are acid fast. Okay, so if they acid fast, they appear bright red color. Okay, and they have this beaded appearance. Beaded appearance is due to because the staining is not uniform. They usually don't have an uniform staining. That's why it appears beaded. And they are long, slender bacilli. Sometimes they are curved, but more or less they are straight. So in order to get positive sputum smear, we have already discussed that the load of the bacilli should be or equal to 10,000 bacilli per ml of sputum sample. And in order to say it's a negative or declare it as negative, we have to scan minimum 100 all immersion fields. Okay, so if you're not getting any bacilli in the first field, then you have to go on scanning. Okay, till you scan at least 100 all immersion fields, and then only if you don't find any bacilli, you can say it's sputum smear negative. So roughly this whole procedure, it takes around 10 to 15 minutes, okay, to scan around 100 fields. Are you clear with this? Can you see the image here?
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am.
So Jadenstein, so we have already discussed Jadenstein. So can you tell me what is the primary dye used in Jadenstein? Anyone? Primary dye? Okay, then tell me why they are acid fast. We have discussed this. Anyone? Can you tell why they are acid fast? Due to which component they are acid fast? What they have, means what makes it different from other bacilli? What they have additionally in the cell wall that makes it acid fast? Anyone? So it's mycolic acid. Okay, understood?
Yes, ma'am.
Okay. So direct microscopy provides only a presumptive diagnosis. Why? Because we can just comment whether it's acid fast or non-acid fast. We cannot comment that it is Mycobacterium tuberculosis. Means we can only know whether it's acid fast bacilli or non-acid fast. So for to say it's Mycobacterium tuberculosis, obviously we have to go for further identification method. Okay, but it gives a preliminary idea whether if the patient is already suspected to have a TB, he is having all the symptoms clinically, it's diagnosed with Mycobacterium tuberculosis, then it can be an additional benefit. But to confirm it, we have to go to the other modalities also. So disadvantage is there with microscopy, that its advantage is that it's rapid and it easily, we can say, like it's easy to perform also, it's rapid also, and it's quite cheap as far as the expenditure is concerned. but it's less sensitive than culture, and detection limit is also there. Detection limit is 10,000 bacilli per ml of sputum. Plus, we cannot determine, means we cannot differentiate Mycobacterium tuberculosis from non-tubercular Mycobacteria. That is one of its limitation. Besides the Jaden stain, the other stain which can be done is quinones coal acid fast staining. This is actually a modification of Jaden stain, where in Jaden stain we need to heat the carbonfusin component, but here heating is not required. Okay, and this carbonfusin, which is actually the primary dye in Jaden stain, it's one of its components is phenol also. So phenol concentration is higher in this format, in this preparation, when the modification of Jaden stain is done. Besides your Jaden stain and modified Jaden stain, the other stains is fluorescent staining. The picture that you can see is actually fluorescent staining. So in fluorescent staining, we use a fluorescent microscope, and this is in a 40x which we are seeing. So you can see the brilliant yellow bacilli, which is fluorescence. Okay, so dye used is 0.1% Oramin. Can you see the image? Are you clear?
Yes, ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
So this is a guideline by RNTCP, okay, Revised National Tuberculosis Control Program for gradation of sputum smear. So why gradation is needed? That is has an importance. Gradation is needed because say if a patient is already undergoing treatment, we want to monitor the treatment response. From the gradation, we come to know whether that is responding well to treatment or not. Secondly, we can find whether how infectious is the patient. How means what is the load of the patient? What is the infectivity of the patient? Okay, so that's why gradation is important. So how will you grade the smear? So after you have examined the smear and you have checked in a per oil immersion field, in a single oil immersion field, you are getting more than 10 bacilli. That means it's a gradation will be 3 plus. Okay, gradation will be 3 plus, but you need to screen at least 20 oil immersion field. Okay, so in 20 oil immersion field, you have to screen minimum 20 oil immersion field. In this 20, every field should have more than 10 bacilli. Then it's 3 plus. Then next is 1 to 10, 2 plus. Okay, so 2 plus gradation means you have to screen minimum 50. So in this 50, every all immersion field is having, say, your bacilli 1 to 10. Okay, so initially the first one for 3 plus, you are screening 20 all immersion fields. In these 20 fields, everyone is having more than 10 bacilli. Then next one, where 2 plus, you are screening 50 all immersion field, and you are seeing that in every field there is at least 1 to 10, means less than 10 actually, 1 to 9 bacilli you can see. Then next one will be 1 plus you have to screen 100 fields. So here also in 100 means total in 100 oil immersion field, the number of bacilli is 10 to 99. It's not per oil immersion field, it's per 100 oil immersion field. Means the cumulative one is 10 to 99. Then next comes scanty. Scanty means you have screened already 100 oil immersion field and you have got around 1 to 9 bacilli per 100 oil immersion field. And say you have screened 100 oil immersion field and not getting any bacilli, that is nil. Nil grading is actually sputum smear negative. Are you clear with the gradation?
Yes,
Anyone
ma'am.
are clear? Any doubt regarding how the gradation system is done? Okay, this is the chart that you have to memorize. So I have already discussed why anticipatory grading is required, because you want to monitor the treatment, you want to assess the severity of disease and assess the infectiousness of the patient. Now, culture methods. Okay. So advantages is that culture methods means it can be anything. It can be a liquid media, it can be solid media, but culture methods. What is the as a whole advantage? So more sensitive, obviously we can detect lesser bacilli. Means we can differentiate whether the bacilli is viable or not. In a microscopy, we cannot say that the bacilli is viable or not. Means it's living or not. It has stain. It's obviously it's present, but viability cannot be assessed from a microscopy. But from culture, in a culture, if the organism is growing, that means it's alive, it's viable. Okay, we use the term viability for this. And sensitivity is also better because we can detect as low as 10 to 100 viable bacilli. So less amount of bacilli can means load when the load is less. It's like 10 to 100. So load is less compared to 10,000. Still it is detectable. That's why it makes this method more sensitive. When something can be detected in a small amount compared to bigger amount, it makes it more sensitive. Next, we can also do drug susceptibility testing. Okay, so this whether you want to see our antitubercular drugs are resistant or they are sensitive. So this DST can be performed in the culture methods. So what are the conventional solid media? We have the LJ media or Lenston-Jensen media. I'll show the image. So can you see one image? That is the Lenston-Jensen media. Okay. So typically we can say rough, tough, buff type colonies can be seen. And in tuberculosis, that is, we can differentiate between tuberculosis and bovis. But tuberculosis is the rough, tough, and buff colonies, and bovis is smooth, moist types of colonies can be seen. So this is the most widely used media recommended by RNTCP. This composition, it is very important for you to know what is the composition of LG media. So it has coagulated Hans eggs, then mineral salt solution, okay, then asparagine, malachite green. So malachite green is a disinfectant. Okay, it's a disinfectant. But here it is acting as a selective agent. Okay, means preventing the growth of other contaminations or other bacteria whichever we are not of any importance. So basically it is using as a selective agent. For this conventional solid median organism to grow, usually it takes around 6 to 8 weeks. Then there is automated lipid cultures. So what is the advantages of automated cultures? First of all, they have a less turnaround time. So usually the growth can be detected around 3 to 4 weeks. So example is Middlebrook 7H9 medium. So this one, the image that you can see is actually a automated system of Bactec midget 960. Why 960? Because actually you can load 960 samples. You can see the cells, different three loading cells are present, and everywhere we can load around 320 samples. The total it makes it 960. So the principle is that in that midget tube, in the broth, you can see one tube on the right side along with the machine. Can you see the tube where there is broth, the midget tube?
Ma'am.
Can you see or not?
Yes, ma'am.
Okay, on the right side. So that tube it has a broth. Okay, so this one is have
Yes, ma'am.
it has oxygen sensitive fluorescent compound. Okay, oxygen sensitive fluorescent compound. So it quenches the emissions from the fluorescent compound. Okay, it's an oxygen sensitive fluorescent compound in the broth, quenches emissions from the fluorescent compound. Okay, but when these organisms will grow in the broth, they will use up oxygen. Okay, they will use up oxygen, and so the quenching effect is lost. Okay, so this is the principle of this midget. So this actually whenever there is growth, we can see some fluorescence. That is because this quenching effect is lost, and quenching effect is lost whenever the organism is grown in the broth and they used up oxygen. Other than this midget, we have VersaTrack and BacteriAlert. Okay, so basically the VersaTrack it detects change in pressure in headspace due to production of carbon dioxide, and also we can see the DST against first line antitubercular drugs. Whereas BacteriAlert is a calorimetric detection of pH change due to carbon dioxide liberated by M. tuberculosis. So basically this midget we are dependent on the oxygen sensitivity. The quenching effect which is lost, it is because the organism is growing and using carbon dioxide. Whereas in other two systems, we are seeing it is because of the production of carbon dioxide. So there is growth, when there is growth, it is subjected to acid first stain, and for further identification, we have to do the other test. So next is MPT64 antigen. So this MPT64 antigen is actually a rapid kit test. It's an immunochromatographic test. So whenever we want to see whether it is specific for tuberculosis, so we can differentiate Mycobacterium tuberculosis from non-tubercular Mycobacteria from this rapid immunochromatographic test. Besides this, we have also biochemical tests and animal pathogenicity which are obsolete nowadays. Serological tests are also not recommended, and it is WHO, World Health Organization, has banned the use of serological tests. Then there is molecular methods. Obviously, molecular methods are important. In tuberculosis, it is the culture, microscopy, and molecular methods which are of utmost importance. So molecular methods, it take less time than culture, It's a more sensitive. Okay, it's usually useful for extrapulmonary samples, and it also detects genes for drug resistance. So in molecular methods, not only we can identify whether the tubercle bacilli is present or not, but also we can see the drug resistance because it will detect the genes. So what are the molecular methods that are used? They are polymerase chain reaction, that is PCR, and CB-NAT. CB-NAT is now very widely used these days. So that is a cartridge-based nucleic acid amplification test. So this system is endorsed by both WHO and RNTCP because in CB-NAT the turnaround time is around 2 hours, and its principle is based on real-time PCR. It works on the principle of real-time PCR. So here we can detect the Mycobacterium tuberculosis complex, DNA, and also rifampicin resistance. Okay. So the entire process, like starting from the processing, nucleic acid amplification, extraction, before that extraction, processing, then nucleic acid extraction, then amplification and reporting. Everything is done. Everything is fully automated. So for extrapulmonary TB, actually GeneXpert or the CB-NAT, it is used as the initial test, especially if the sample is from CSF, lymph nodes and tissue specimens. So its sensitivity is very low. Sensitivity is very good. Sensitivity is 131 bacilli per ml of specimen. So disadvantages are very expensive, and it cannot further speciate because it is detecting the TB complex as a whole. So this is the GeneXpert machine that you can see, and that is the blue color structure that you see, that is the cartridge. Okay, so that cartridge, it has a barcode. Okay, and in this machine we can process 4 samples at a time. Then another important modality is a line probe assay, but a line probe assay is usually done from the sputum smear positive sample. Okay, usually it's done in case of positive cultures or smear positive clinical samples. So you can also here also you can detect the MTB complex and drug resistance to first and second line anti-tubercular drugs. And there is speciation of TB complex and NTM, means non-tubercular mycobacteria. So the commercial kits which are in use are genotype and immunolipal. These are some of the examples. So it has a turnaround time of 2 to 3 days. Okay. So DNA is extracted from clinical samples, then it undergoes. There is multiplex PCR amplification. Okay. So these are the different steps which are followed. So you should know this is the one disadvantage which it has is that can be performed only on positive cultures or smear positive clinical specimens. So it is useful in isoniazid monoresistant cases which are not diagnosed by GeneXpert. So GeneXpert, we are diagnosing rifampicin resistance. Okay, that is the mutation RPOB gene. So LPA is used to find check for resistance of isoniazid. Besides this, upcoming methods are TrueNAT. This is one more another modality which is upcoming methods for TB diagnosis. Then TB-LAM, next generation GeneXpert. Okay, these are some other new modalities. Bread biomarkers, LAM antigen detection, intergamma, rapid immunosuspension assay, then automated microscopy, and besides non-commercial culture and drug susceptibility testing. Now, this is an old guideline of 2016 of RNTCP. So here, I just want to explain what is a presumptive pulmonary TB. Okay, presumptive pulmonary TB means it's not yet confirmed, but it is suspected to have pulmonary TB. So what are the symptoms which is exhibited by, which are shown by those patients? So the patients have cough. Duration of cough is more than 2 weeks. Fever more than 2 weeks. There is significant weight loss. Okay, hemoptysis means cough or expectorant mixed with blood. Okay, and abnormality in chest X-ray. Okay, you can see basically you can see some findings in the chest X-ray. So we also have presumptive drug-resistant TB. So one is presumptive pulmonary TB, and this is another term for presumptive drug-resistant TB. So TB patients, what is presumptive drug-resistant TB? TB patients who have failed treatment with first-line drugs, then pediatric TB non-responders, then TB patients who are contacts of drug-resistant TB, TB patients found positive of any sputum smear examination during treatment within first-line drugs, previously treated TB case, and new TB patients with HIV co-infection. So this is the definition of Means this under all of them, this falls under drug-resistant TB, presumptive drug-resistant TB case. Now this is an algorithm for RNTSP, means what we are supposed to do. Protocol for as per NTSP guideline of 2016. Say we are suspecting a patient like presumptive TB, we'll first go for we'll go for both smear examination and chest X-ray. Okay. So in smear examination, we are getting positive. That means it is microbiologically confirmed as TB. But if it is smear negative, but chest X-ray is still suggestive, so we can go for CB-NAT. That is the molecular method which we have discussed just now. But again, smear and chest X-ray both are not suggestive, okay? But still, where there is high suspicion, we can still go for CB-NAT. But certain conditions like PLHA, PLHA means patient living with HIV infection, HIV/AIDS, pediatric non-responders, then extrapulmonary TB or presumptive drug-resistant TB. For them, it's better you go directly to CB-NAT. Okay. Now in CB-NAT, we can detect two things. We can either detect the presence of the tuberculosis MTB complex, or we can also see the rifampicin resistance. Say MTB is detected, then we'll go for rifampicin. So rifampicin may be sensitive or indeterminate or resistant. So if rifampicin is resistant, we can just refer for management as rifampicin resistance. But if it is indeterminate, we have to repeat CB-NAT on second sample. Means we have to ask for one more sample and we can repeat CB-NAT. Even if on second sample still it is indeterminate, we have to collect fresh sample for lipid culture or LPA. Okay. So in CB-NAT, MTB is detected, rifampicin is indeterminate. So we ask for a second sample and repeat CB-NAT. So even after the second sample in CB-NAT is showing indetermination, then it's better if it is still indeterminate, then we have to ask for fresh sample, which we can go for lipid culture or line probe assay. Now, in CB-NAT, MTB is not detected or CB-NAT result is not available, but there is high suspicion clinically, so it is clinically diagnosed as TB. And if microbiome tuberculosis is not detected by CB-NAT and clinically also it's not suspected that much, then it's not highly suspected, there is no suspicion, then we can also consider alternate diagnosis. So all presumptive TB cases should be offered HIV counseling and testing, because okay, so we have this comes like both TB and HIV counseling should be offered simultaneously. Are you clear with the algorithm? Is it clear? This chart is clear or not?
Yes, ma'am.
So next is for pediatric presumptive pulmonary TB. So CB-NAT, as I have already mentioned, CB-NAT is directly performed on sputum. Okay. So if it is not detected, we can also check X-ray and tuberculin test. So tuberculin test, it's actually what is a tuberculin test? That is a Monto test. Okay, where we can look for delayed type hypersensitivity reaction. It is of importance in pediatric age group, because in older patients or adult age group, it doesn't only mentions, doesn't only detects the active infection, but sometimes the past infection also can be like we cannot give a conclusion whether it's an active infection or past infection in case of adults. But in case of children, if someone is tuberculin test positive, means the Monto test is showing positive results, then usually it means that there is an infection. Then say there is highly suggestive chest X-ray like miliary sedos or hilar mediastinal limb adenopathy, CB-NAT can be performed on alternate specimens, means other than sputum samples. Alternative specimens, it can be gastric aspirate or induced sputum. So in children, gastric aspirate is a very important sample. And where is non-specific chest X-ray, we can also think for other diagnosis, alternative diagnosis like bacterial pneumonia, and still symptoms is there is persisting symptoms, then we can repeat CB-NAT on alternative specimens. So microbiome typing, I will not go into details, but the different names you can just know what are the different modalities to do typing of Mycobacteria, because it is of epidemiological importance. So you have PCR, RF, LP, then Spoligo typing, pulse field gel electrophoresis, and DNA sequencing. Now tuberculin test is utilized for diagnosis of latent tuberculosis. So by demonstration of type 4 hypersensitivity reaction against the tubercle bacilli antigens. So earlier the antigens which are used was old tuberculin. Now it's a purified protein derivative antigen. So this purified protein derivative RT23 with 2 in 80 purified protein derivative is recommended by WHO. So this one tuberculin unit is equal to 0.01 milliliter of whole tuberculin or 0.00002 milligram of purified protein derivative. So Montauk test, what is the procedure? You have to inject this amount intradermally into the flexor surface. Okay, there's one more tuberculin testing, that is Heath and time multiple puncture, which is obsolete nowadays. So after Montauk test is done, we have to take the reading usually between 48 to 72 hours, and we have to look for induration. Induration, you know what is induration? You know or not induration? Anyone?
No, ma'am.
You don't know. Induration is the thickening of the skin that you can see. Okay, that means there's a particular area, the flexor aspect, no, the interdermally the tuberculin is injected, we'll mark that area and we'll look for the reaction at the end of after 48 to 72 hours. We look for any changes in the skin texture. That means there will be some thickening of the skin. So if the zone, we have to measure the zone of that thickening of the skin, that is the induration. So if it is more than 10 or equal to 10, is it a positive reaction? If it is 6 to 9, is equivocal. So equivocal, that means again we have to repeat the test after, say, after a few days. Okay, after 10 days or like that. We have to repeat the test. We'll look for next time we'll look for whether the induration size has increased or not. Okay. Next, less than 5 millimeter means it's a negative reaction. So in case of, I have already mentioned, interpretation of result in adults, positive only indicates present or past exposure with tubercle bacilli. So it's used as an epidemiological marker. While children, positive test indicates active infection and used as diagnostic marker. That's why in pediatric non-responders, tuberculin test, I have already shown you the slide. So if MTB is not detected, CBNAT is not available, then we can look for chest X-ray and tuberculin test. So this has an importance in pediatric age group. So in tuberculin test also we have certain cases of false positive or false negative. False positive is the patient is BCG vaccination. Okay, BCG vaccination or non-tubercular mycobacteria infection can show a false positivity, whereas false negativity is seen in patients with like decreased immunity, like especially cell-mediated immunity when it's impaired, like HIV infected patient, or very advanced stage or very early stage of TB. And in the extreme of the stages, it can be a false negative, or when there is a disseminated TB like miliary TB, then also there can be a false negative. Now, what is two-step testing in adults? When we repeat the test after 1 to 2 weeks after the first dose, so because of a booster effect, the positive reaction becomes very strong. That means the zone of induration, it becomes more than 20 millimeter. So that is two-step testing. These are the other modalities of diagnosing latent tuberculosis other than Montauk test or the tuberculin test, that is interferon gamma release assay. Okay, then quantiferon TB gold. Now, coming to the treatment of tuberculosis, we should know what is the first line drug and second line drugs. Okay, and these things will be discussed in pharmacology also. So, in details, we will be studying all the mechanism all in pharmacology. But here, I just want to discuss which comes under first line is isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. Second line, you can see the entire list: the ethionamine, protonamide. In quinolines is levofloxacin, moxifloxacin, afloxacin. Aminoglycosides like kanamycin, streptomycin, amikacin. Then cycloserine and para-aminosalicylic acid. Macrolides like clarithromycin. And bedaquiline is the most latest, which is approved in 2015. There's other agents also with unclear efficacy like clofazimine, linezolid, amoxicillin clavulanic acid, thiacetazone, meropenem, clavulanic acid, imipenem, cilistatin, clarithromycin. So you go through the names. Okay, try to remember them. Now we should know what is a multi-drug therapy. So what is short course chemotherapy? So short course chemotherapy usually lasts for 6 months or 8 months in previously treated cases. So this chemotherapy is given in two phases. One is the intensive phase, one is the continuation phase. So intensive phase usually it is around 2 to 3 months, while continuation phase is 4 to 5 months. So intensive phase is directed towards aggressive treatment that it rapidly kill bacilli, making the patient smear negative, while continuation phase is targeting the dormant bacilli and it's preventing relapse. So intensive phase is targeting the active bacilli actually, try to decrease the bacilli load by killing the bacilli, and continuation phase is trying to kill the dormant bacilli and preventing relapse. So DOT strategy, directly observed treatment short course, which is recommended by RNTSB and WHO. So treatment course is supervised. Obviously, this is supervised to improve the patient's compliance. Okay, and it's monitored. Response is monitored by sputum smear microscopy at the end of each phase. So this entire DOTS whole course is actually supervised under a healthcare supervisor to improve the patient's compliance to treatment. Okay, so in TB treatment, the once the patient starts the treatment, he has to take the required amount of dose, the required amount of drugs for a required time. Means he cannot skip his medication. He cannot give a gap. So it's the entire the treatment has to be supervised. Next is we can monitor the sputum smear microscopy. Means at the end of each phase, means it's the initial is the intensive phase that I have seen, and then there is a continuation phase. Okay, so after end of intensive phase or in between, we can means at the end of each phase we should check for the sputum smear, okay, microscopy. So dosage is fixed dose combination to aspire appropriate weight bands and it given daily. Weight bands means according to weight of the patient, the dose is adjusted and it's given in a combination of drugs. So you can see the different category of patients to whom it falls. Category 1 is new patients. New patients mean newly diagnosed patients which have received antitubercular drugs for less than 1 month. So what is their regimen? For intensive and continuation phase, for intensive phase, the regimen is for 2 months, and it has combination of isoniazid, rifampicin, okay, pyrazinamide, and ethambutol. So those 4 drugs as a combination we have to give for 2 months, and for continuation phase for 4 months, you have to give isoniazid, rifampicin, and ethambutol. Now, category 2 means previously treated patients which have received more than or equal to 1 month antitubercular drug. That means treatment after failure means the treatment has failed. Recurrent tuberculosis infection, recurrent, or after treatment after loss to follow up. So in those categories, we have to increase the duration of treatment to 8 months. So the intensive phase is actually 3 months here, continuation is 5. For intensive phase, for initial 2 months, you will be adding isoniazid, rifampicin, pyrazinamide, whereas the last 1 month you will be giving isoniazid, rifampicin, pyrazinamide, and ethambutol. In the continuation phase, you are giving isoniazid, rifampicin, and ethambutol. Follow-ups will be done during treatment and after completion. So there is resistance to antitubercular drugs. There is primary drug resistance and acquired resistance. So this primary drug resistance is an infection of an individual by drug resistant strain, means he has already acquired a strain which is drug resistant. It is the patient is not previously treated, okay, and this is a less common situation. Whereas the acquired resistance or second year post treatment, so initially the patient was sensitive to drugs, to intertubercular drugs, but later they become resistant. This is due to inappropriate or inadequate treatment. It's more common situation. So why drug resistance occurs? It is due to point mutation in genome of M. tuberculosis. Failure to adhere to multi-drug regimen is the most important reason. That is why it's very important to monitor the treatment, means to give the treatment under observation, because otherwise it may lead to not only failure of treatment but also multi-drug resistance. So there are certain situations where this multi-drug regimen may where the failure to adhere to multi-drug regimen is the most important reason, like prolonged duration of regimen, poor compliance, development of toxicity to drugs, improper supervision follow-up, irregular supply of drugs, and incorrect prescription. So these are the terms that is important in case of drug resistance to anti-TB. Monoresistance means resistance to one first-line anti-tubercular drug. First line, those 5, any resistance to any. Polyresistance means resistance to more than one first-line except INAs and rifampicin together. Rifampicin resistance means without or resistance to other ATDs, excluding isoniazid. Because if both rifampicin and isoniazid resistance are there, that means it's multi-drug resistant. So MDR-TB means resistance to isoniazid and rifampicin with or without resistance to other first-line drugs. So for MDR-TB, we have DOTS plus program. Okay. So the intensive phase for 6 to 9 months, continuation phase is for 18 months. So intensive phase, we can give kanamycin, ofloxacin, levofloxacin, ethanamide, cycloserine, pyrazinamide, ethambutol. Continuation phase, ofloxacin, levofloxacin, ethanamide, cycloserine, ethambutol. So these are more expensive and highly toxic than first line ATDs. About the second line drugs, they are telling the second line drugs are more expensive. They are highly toxic. Can you understand? Any doubt?
No, ma'am.
Okay. So for you, you should know what the terms like MDR-TB and XDR-TB. So MDR-TB means resistance to rifampicin and isoniazid, with or without resistance to other drugs. But what is XDR-TB? So XDR-TB means MDR-TB cases also resistant to fluoroquinolones like ofloxacin, levofloxacin, and at least one injectable aminoglycosides like kanamycin, amikacin, or capreomycin. Okay, so this is the definition of XDR-TB, and it's very difficult to treat XDR-TB. So what are the global and national TB programs? So we have revised National Tuberculosis Control Program, the NTB strategy, National Strategic Plan, NICSHI. But now this National Tuberculosis Elimination Program. So what is the National Tuberculosis Elimination Program? The revised National TB Control Program has been renamed in 2020, that means last year, as National Tuberculosis Elimination Program with the goal of eliminating the disease by 2025. So now we don't have RNTCP, currently we are having National Tuberculosis Elimination Program. So prophylaxis against tuberculosis, we can take BCG vaccination, okay? So there are also complications following BCG vaccinations, okay, like ulceration. So I will not go into BCG now because just remember that is one of the modality used for prophylaxis against TB. So we'll discuss here we'll end TB and we'll start the deep mycosis. So first we should know what are the fungus. Okay, this is a new topic. So fungus responsible for systemic mycosis or deep mycosis. There are four. Okay, this is histoplasmosis that is caused by commonly is Histoplasma capsulatum. Then we have blastomyces dermatitis, Coccidioides immitis, and Paracoccidioides brasiliensis. Okay, coccidiomycosis is one, and Paracoccidiomycosis. So I'll just go through them. They more or less they have similar pathology. So this systemic granulomatous disease is caused by dimorphic fungus. So whatever the fungus we are discussing here for, all of them are dimorphic. Dimorphic means two types of morphology. One is the yeast form, one is the mycelia form. So yeast form usually found in the human inside the human body, where in the growth in the fungal culture you can find the mycelial form. Okay, so three varieties of plasmosis there. This is Histoplasma capsulatum, variety capsulatum, then Dubosi and Farsi. So basically, it's endemic in United States. In India, it's found in the West Bengal. So how it is spread? Pathogenesis is because from a contaminated soil, there is inhalation of spores or microconidia, which are engulfed inside the alveolar macrophages and they transform into yeast forms. That means they inside the alveolar macrophages, once they are entered, they convert themselves into the yeast forms. So yeast survive within the macrophages because they can also inhibit this phagolysosome. So they within the they can evade this system and they are then the yeast form which are carried to the lymph nodes and to different parts of the body through bloodstream. So majority of the patient who had got this infection, they saw strong cell-mediated immune response within. If there is a strong cell-mediated immune response, within 2 weeks there will be granuloma formation, which is cell classification, and it's rarely reactivates. But if there is an impaired CMI, it can be dissemination infection. So, classical histoplasma ranges from asymptomatic to life-threatening illness seen in people with cell-mediated immunity. So, different forms of histoplasmosis are pulmonary, which can be again acute and chronic, then mucocutaneous histoplasmosis, and disseminated histoplasmosis. So, what are the specimens? We'll collect sputum, then spread from bone marrow, lymph node, blood, and biopsy skin mucosa. So direct microscopy, if you do in histopathological staining, that is your periodic acid skip, Giemsa and Gomorrhea methionine silver. These are the commonly used stains. So you can see the yeast cells. Yeast cells have a narrow base budding. The size of the yeast cells is 2 to 4 micrometer and they have narrow base budding within the macrophages and the underlying granulomatous response. So culture is the gold standard method of diagnosis. So Savarot, dextrose agar, Blal agar, Brainerd infusion agar, these are used and they are put in duplicate at two temperatures. One is 25, one is 37. So in 25 degrees Celsius, there have the mycelial phase, okay, or the mole phase, which is gives colony color white to brown. buff brown colors, and here we can see the tuberculate, macroconidia, and the microconidia. Okay, so these are the spore formations with macro and micro both. So tuberculate macroconidia is a typical thick walls and finger-like projection. So you can show the image here. You can see the first image is the yeast cells within the macrophage. Then there is another structure showing microconidia and macroconidia. So macroconidia, we can see the finger-like projections, and there is, you can see the LPCB mount on the extreme right where they are showing the macroconidias, and there is one histopathological stain where we can actually see the yeast cells. So microconidia are smaller, thin and smooth wall, and at 37 degrees Celsius we can see the yeast form. So serological test we can detect antibody, complement fixation test, and immunodiffusion, and where we can say some false positive cases if there is a cross reaction in other fungus like Blastomyces. Besides this, the other modality is skin test, where you can say the hypersensitivity reactions. We can check delayed type hypersensitivity reactions to histoplasmic antigen, and molecular test we can go for PCR. For treatment, we have to give liposomal amphotericin B, which is for acute pulmonary and dysentery histoplasmosis, and itraconazole can be given for chronic cavitary pulmonary histoplasmosis. These are different variety, Dubosian, Parsiminosum. Next is blastomycosis, so also known as the Cricker's disease or Chicago disease, North American blastomycosis. Full name is Blastomyces dermatitis, is a dimarchy fungus. It is also transmitted by inhalation of the conidia. So spores are engulfed for alveolar macrophages where they get converted into yeast phase. So this is very much similar to the previous fungus. Here they have one additional virulence factor, that is your Blastomyces dermatitis adhesine 1. So this has a inducer of, is a major inducer of cellular and humoral immune response. Blastomycosis and extrapulmonary manifestations. Okay, like skin, osteomyelitis, skin involvement, osteomyelitis, abscess, prostate, CNS. So endemic in North America. So you can see the lab diagnosis. If you do histopathological staining of the tissue biopsy, the thick-walled round yeast cells of 8 to 15 micrometer size with single broad-based budding. That means finger of 8. So you can see the image showing both mycelial form and the yeast form. And yeast form, you can see there is a broad-based budding. That's why the finger of 8. Even on the histopathological stain with the arrow mark, you can see the yeast form. So culture media is same, SDA, blood agar BHI. So you have to incubate at 25 and 37. T25 get the mycelial form, and 37 find the conversion of mole to yeast. Okay, you can go for skin test, that is blastomycin antigen, delayed type hypersensitivity to blastomycin antigen, antibody detection. Then we can go for antigen detection also. Molecular methods like DNA probe, hybridization, real-time PCR. Treatment is almost similar. Liposomal amphotericin B is a drug of choice. And itraconazole in case of immunocompetent patients with mild pulmonary or non-CNS extrapulmonary blastomycosis, means other than CNS involvement, any other extrapulmonary we can treat with itraconazole. Then next is coccidiomycosis, also known as desert rheumatism or valley fever, California fever. It has two species, Imitis and Poseidaceae. So pathogenesis is transmitted by inhalation of arthroconia. So more or less they are all similar mechanism, but here the conidias are arthroconidia. So arthroconidia are actually rectangular shaped conidias, and so once they enter lungs, they become enlarged and they develop internal septations, like they form a sac-like structure where they contain they encompass numerous endospores. So this size of the sac is around 200 micrometer. Okay, and they rupture and they release those endospores which then disseminate and then develop into new spirules. So most patients are asymptomatic. So there is pulmonary coccidiomycosis, then skin lesions and disseminated forms. It's endemic in certain parts of Arizona, California, in United States. If you can see the picture, this is actually you can see the endospores inside. Okay, spirule. Okay, the 200 micron, that is the average size, and inside that spirule we can see those smaller structures. These are endospores, and this is histopathological staining, the image. Okay, so large sac 20 to 80, okay, they have mentioned. Okay, it can go up to 200 also. It says have thick doubled refractile wall and filled with endospores. So in SDA mission culture, fungal culture media, it is a mycelial growth described as fragmented hyphae, consists of barrel-shaped arthrospores with alternate cells distorted. So you can see the image. First one is the spirule with endospores. Next is your arthroconidias and the empty cell. So arthroconidias, you can see they are rectangular. So here, same thing in histopathological staining, I'm trying to show the spirules with, and the other one that is your LPCB mount showing the arthroconidiosis, and in between we can see the empty cells. So crocodiles differ from other dimorphic fungi because it is grows as mold at both 25 and 37 in each culture. So normally in the other systemic mycosis, you can see those in the at 25 degrees Celsius they are mold form, at 37 they are yeast, but here at both 25 and 37 they are mold form provided they are growing in culture media. Okay, in human body it will be yeast form, but in culture even at 37 degrees Celsius they are showing your mold form. So the spherules are certainly formed at 37 degrees Celsius in special culture media. So other tests we have serology, skin test. Treatment is similar, like itraconazole is a drug of choice, and for diffuse pneumonia with pulmonary sequelae, amphotericin B is used. Last one is the paracoccydomycosis, so also known as South American blastomycosis, Lutz splendor de Almeida disease. So it's systemic disease caused by dimorphic fungus Paracoccydoides brasilensis, so endemic in Brazil and other South American countries. So it's transmitted by inhalation of spores, which have two forms. So you can see the acute form, chronic form. Okay. So acute form usually occurs under 30 years of age. Okay. It's less common but more severe, and also disseminated infection involves multiple viscera and is refractory to treatment. Whereas the chronic form is known as the adult form, which is the more common form. So results from reactivation of quiescent lung lesions. So histophysical staining, if you do for different samples like pus, tissue biopsy, sputum, you can see the round thick wall yeast with multiple narrow neck buds attached circumferentially. So Mickey Mouse or pilot wheel appearance. You can see the image. You can see one big yeast along with two small buds in the above picture, above image. That is the Mickey Mouse form. And the pilot wheel is that the one is surrounded by many small buds, many narrow base small buds. That is the pilot wheel appearance on the middle image. And then on the left side, you can see the mycelial form. So SDA culture, it is mycelial form at 25, while which converts into yeast phase at 37 when grown in BHI agar, supplemented blood and glutamine. Serological test, you can go for antibody detection, okay, like immunodeficient ELISA, and skin test. So treatment also, intraconazole, which is a drug of choice for seriously ill patients, amphotericin B. Okay, itraconazole is a drug of choice for seriously ill patients, amphotericin B can be given. And sulfonamides are effective, but the response is slow with frequent relapses. Thank you. So any doubt anywhere?
No, ma'am.
Okay. Okay, then see you in next class.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.